Hi, my name is Arya Kieft and I am a radiation oncology resident, and today I will be presenting my poster on the experience with Lu-Dotatate in patients with metastatic gastroenteropancreatic neuroendocrine tumors at a single urban cancer center. Gastroenteropancreatic neuroendocrine tumors, or GEP-NETs, are a rare and heterogeneous group of malignancies that arise from neuroendocrine cells or their precursors. There are approximately 23,000 cases diagnosed annually, and the incidence of this disease has risen since 1973, particularly in people over the age of 65. These tumors are classified based on location of primary, the stage, the grade, and the differentiation. Unfortunately, patients who develop these tumors are rarely symptomatic in the early stages and are more commonly diagnosed when the disease is advanced, locally or distantly. Once diagnosed with metastatic GEP-NETs, treatment options include local therapies such as surgical debulking, chemoembolization, and liver transplantation. External beam radiation therapy. Systemic therapy for GEP-NET has come to rely on a targetable feature of well-differentiated tumors, which is the expression of somatostatin receptors. Somatostatin analogs have been found to be effective in controlling cell proliferation in phase 3 clinical trials, but the drawback of these well-tolerated medications is that they are not cytoreductive. They slow disease progression, but they don't decrease disease burden. Radiotherapy is a cytoreductive modality, but the disseminated nature of the disease makes external beam radiation therapy to all sites impractical, if not impossible. Since the 1990s, chelating a radionuclide that emits cytotoxic radiation to a targeted molecule has been investigated. There is currently one FDA agent approved for the treatment of GEP-NETs, which is a lutetium-177 atom, which emits beta particles, linked to a somatostatin analog, octreotate, by a chelating molecule called DOTA. The compound is infused intravenously and travels preferentially to tissues expressing somatostatin receptors. The FDA approval of this compound was based on the NETTER-1 trial, which compared Lu-Dotatate and octreotide with high-dose octreotide alone in patients with low-grade small bowel primary NETs. The patients who had the combination of Lu-Dotatate and octreotide had improvement in progression-free survival and a trend towards improved overall survival. We were interested in the outcomes of the patients treated with Lu-Dotatate at our facility, which has a more diverse population than that which was studied in the NETTER-1 trial. We were also interested in any differences in outcomes for patients with pancreatic primaries compared to small bowel, higher tumor grade, and different histories of systemic therapy. The patients included in this review had histologically proven GEP-NETs. They had progressed on systemic therapy that had to have included an SSA and received at least one dose of IV Lu-Dotatate at our facility. The Lu-Dotatate was administered per the NETTER-1 protocol with hydration, antiemetics, and renal protective amino acids via a PICC line. Patients were educated on radiation safety, and laboratory evaluations prior to administration were done to review liver and kidney function, as well as hematologic fitness to proceed. Demographic, imaging, pathology, and other clinical data were collected from electronic medical records. Toxicity was graded based on the CTCAA version 5, and progression was determined by review of imaging reports and RECIST criteria. We reviewed the record of 51 patients treated between December 2017 and September 2021. 42 of these patients completed a minimum of 3-month follow-up imaging. Median age of patients at the time of first infusion was 66 years. The most frequent primary tumor was the small intestine. 70% of patients had this primary. All of the patients were metastatic, and all patients except for one had liver involvement. The median time from initiation of first-line systemic therapy to first Lu-Dotatate infusion was 3.65 years, and time from initial diagnosis to first infusion was 4.25 years. Toxicity data were similar to the NETTER-1 trial, with CTCAE grade 3 or 4 hematologic toxicity occurring in 14% of patients. Of the 42 patients with follow-up imaging, 29% had partial response, 45% had a mixed or stable response, and 36% had progressive disease. The median overall survival time was 2.13 years, and the median progression-free survival time was 1.46 years. We found no difference in toxicity, overall survival, or progression-free survival by tumor site, performance status, prior systemic treatment history, or patient-reported race. Analysis was limited by the small number of patients. We, however, do conclude that Lu-Dotatate appears to be safe in the patient population treated at our center. Looking to the future, a secondary analysis of NETTER-1 found that the larger the target lesions, particularly in the liver, the worse the progression-free survival after Lu-Dotatate administration. Offering this cytoreductive therapy to the patients earlier in the disease course, when tumors are less than 3 centimeters, may improve outcomes and would be an area of future research interest. This concludes my presentation on the experience with Lu-Dotatate at our facility. Again, I'd like to thank you for your time and attention.